When a patient is hospitalized, efficiently managing their care from admission to discharge is critical. Hospitalists ensure patients get the care they need. Their goal is to focus on a shorter length of stay, lower costs, and better coordination of high-quality care for the patient. Stay tuned to find out more about the role of hospitalists in your Catholic Health Services of Long Island hospitals on today's episode of CHS Presents Lifestyles at the Heart of Health. Hello, everyone, and thank you so much for joining us. I'm Jane Hansen. Hospitalists are playing an increasing role in the delivery of health care, and joining me today to share how the rise of hospitalists can actually benefit patients immensely is Dr. Michael Klott, Chief Hospitalist at St. Catherine of Siena Medical Center and the Chairman of Hospital Medicine for Catholic Health Services. Welcome. It's good to have you here.
No, thank you very much, Jane.
So tell everybody exactly what a hospitalist is.
Absolutely, yeah. So hospitalists are board-certified physicians who specialize in the care of acutely ill patients in the hospital environment. Just to put it a little bit more simply, they're experts in inpatient medicine. So as you remember years ago, when you got ill, you had to be in the hospital, your primary care physician used to come in and see you in the hospital environment. Now the pendulum is shifting. It's going the other way where your primary care physician is more focused in the office, their office-based practice, and now they're utilizing us as hospitalists to admit the patients and discharge patients. And the reason why the pendulum shifted that way is because we're available 24/7, 365 days a year. The need for hospitalists is very high because patients are very complicated. As you know, the geriatric population is rising. They have multiple comorbid conditions. They have heart disease, diabetes, kidney disease, you name it, and they're on a slew of medications.
Right.
So if you put all these things together, and they come in with their acute event, what they're coming in for, whether it's stroke or sepsis or what have you, the care gets a little bit more complicated. You need that hospitalist there to navigate that care, coordinate that care throughout this hospitalization.
Well, it makes sense because if I think about my primary care doctor, they're just not so available. They can't, for them to get to the hospital if you had an emergency. And also, isn't it true that a lot fewer people are going into the hospital for regular procedures? They're having them done in either outpatient clinics or that sort of thing. So is it true that maybe people are sicker when they go to the hospital?
Yeah, so the shift has now, the paradigm has shifted to more ambulatory. So taking care of procedures that used to be taken care of in the hospital are now being taken care of in the outpatient setting. So yes, we are getting sicker patients. So I kind of say that hospitals one day are going to be one giant ICU.
Yeah.
So the sickest of the sick will be hospitalized, and the not too sick will be taken care of on the ambulatory side.
So I'm assuming your answer to this question is going to be technology. But what occurs to me is this is all well and good that you're specialized in that, but people have a special relationship with their primary care doctor who knows their history. And if they're coming in an emergency room situation, they may not even be cognizant enough to say, oh, yeah, I've got a heart history. Oh, yeah, I just saw my doctor about X, Y, or Z, because they may be a little dazed or out of it. So how do you do that?
Right. So that's a very good question. I mean, number one, we have an EMR that communicates. So
emergency medical records, EMR?
It's the electronic medical record.
I'm sorry, electronic medical records.
So it's called Epic. It's a great program because I could say, let's say the patient about a month or two ago was at Good Sam or at Mercy or at St. Joe's. I can read the chart. I can see what kind of testing they underwent. I could see what the consultants did. So that's one thing. Definitely the EMR is very, very helpful to wrap up and tell me more about that patient. And also it goes without saying, I just don't rely just on an EMR. I also rely on calling the primary care physician as well. I'll give you an example. I had a patient that came in about a month ago with pain, chest pain, angina, and we almost admitted that patient when I was talking to the ER physician. We almost admitted that patient, but it took me a couple of phone calls, one to the cardiologist and one to the primary care physician, and lo and behold, The patient had a whole battery of tests and was completely cleared. I had a stress test, coronary angiogram less than 3 weeks ago, and I ended up discharging that patient. So speaking to the primary care physician actually changed my plan totally from admitting the patient to discharging that patient.
So what was wrong with them? Just kind of acid gas reflux or whatever it's called,
so-
or an upset stomach?
Yeah, there's a lot of causes for chest pain. It could be musculoskeletal. It could be reflux disease, GERD. So, I mean, just because somebody's coming in with discomfort in the chest, everybody gets very nervous, you know. The emergency room physicians also get very nervous and say, well, we need to admit, we get nervous too. But when we have that information handy, especially in our EMR or talking to that primary care physician, we feel more comfortable. We can discharge that patient back to the primary care physician, you know, hopefully have a follow-up within the next 24, 48 hours and look at other causes for that indigestion.
And then sometimes there are things that come into an emergency room that maybe because you're a hospitalist and in hospital all the time, you may be better able to diagnose than a primary care doctor might be able to diagnose. Some kind of an infection, something like that.
Yeah, so if you think about it, I mean, the amount of time we spend in the hospital, you know, we spend a lot. So we get very good at it. So I would say we're hospital medicine experts. So if I do it all day long, I get very good at it. So I could identify sepsis. I could identify a pulmonary embolus, which is a clot to the lung, as opposed to the primary care physician who's not there very long. You know, he sees their patients in the morning and has to run to the office because he's got obligations. He's got patients waiting to see him. So in my opinion, yeah, I mean, our skill set as far as acute care medicine is higher than a general practitioner. Now, having said that, you put a hospitalist in the office setting, you know, we're not as good as the primary GP, right?
So it almost sounds like it's a specialty then, being a
right,
hospitalist.
Exactly.
And do people actually, is this something that you can now train for in medical schools?
Yeah, so it's medical school training is the same for everybody. There are fellowships now in hospital medicine that are available, so you can get a certification in hospital medicine. You don't necessarily need one. Like for example, I'm board certified in internal medicine and geriatric medicine, and that also gives me a lot of amplitude in my knowledge base as far as hospital medicine.
So do you think that this actually can ultimately, because the patient you just described, for example, with him not being admitted to the hospital, that saved thousands of dollars in medical costs for the patient, for the system, for the insurance, for everything. Is it ultimately, does it mean it's more cost efficient?
Well, yeah, definitely. I mean, being a hospitalist, you're trying to advocate for that patient. And we also assess appropriateness of admission. So if the patient doesn't need to be admitted, number one, that's good quality care because you don't want to put a patient in the hospital if they don't need it, right? They can catch other things, they can catch infection. And also being cost effective, we try to discharge them as fast as we can, safely, that is. There's a myth that patients and caregivers think, well, the longer I stay in the hospital, the better off I am. In this case, more is not better. So when you get better from your pneumonia or you get better from whatever event you came in with and you're stable for discharge, then at that point, we've got to get you out. I mean, just if you think about it, elderly people, the more they stay in the hospital and the more immobile they become, the more deconditioned. And what is the hospital filled with? It's filled with sick patients, right?
Yeah,
They either
right,
have
of
pneumonia,
course.
they have the flu, they have viral
course.
illnesses. You don't want to go in with one thing and then walk out with another. So, yeah, so we try to expedite, reduce the length of stay. So that is a cost-effective and a quality issue, too.
But what about the notion that a patient has a primary care doctor that they really trust, and now all of a sudden they're meeting somebody new, such as yourself, and you got a good-looking face there. But I'm just wondering, how do you deal with that? Because psychologically there may be some kind of impact.
Okay, so when I first meet the patient in the emergency room, there is an anxiety level as far as the patient is concerned. I mean, the first question is, you know, who are you? You know, what's a hospitalist? And when is my doctor coming? Okay, so I start explaining to them and I educate them right at the get-go. what our responsibilities are. And I kind of ease their anxiety by telling them that I'm in close communication with their primary care provider, and which we are. So when we admit somebody, we call them at admission, we call them on discharge to tell them what our plans are. And also, if there's any change in clinical status during their stay, the primary care physician is also spoken to. So it seems to me, I mean, it hasn't been an issue, and they seem to calm down as long as they have that idea that we are constantly collaborating and coordinating care with their primary care physicians.
Sure, that's got to bring a lot of relief after the. I mean, everybody gets anxious when they go to the hospital in the first place. Anyway, no matter who's there with them. So, we're going to take a quick break, and when we come back, we'll take a look at a day in the life of a hospitalist. So that's coming up right after this. Welcome back to CHS Presents Lifestyles at the Heart of Health. With me today is Dr. Michael Klott, Chief Hospitalist at St. Catherine of Siena Medical Center, the Chairman of Hospital Medicine for Catholic Health Services as well. Now that we have learned all about the role of a hospitalist, let's take a look at a day in the life.
Knock, knock. Hi, how are you? I'm Dr. Montanu. I'm the hospitalist. I just wanted to come to introduce myself and see how you're feeling. This is Jen. She'll be your nurse for the day.
Nice to meet you.
I'm Dr. Montanu, hospitalist at St. Catherine of Siena Medical Center. I specialize in internal medicine, and we take care of patients that are acutely ill in the hospital when their primary care doctors are unable to come and care for them. Hospitalists admit the patients, and we take care of them during their hospital stay, and we also discharge them, and we communicate with their primary care doctors after for continuity of care. We actually care for a lot of different types of admissions, whether it be trauma surgery or a broken bone. We work very closely along with the surgeons, so we do take care of most of the people in the hospital. Along with the other consultants, we all work as a team. From the beginning, when I take care of my patients, I like to introduce myself and make sure that they know my role, and they know that I'm the captain of the ship, but we all work as a team. And I like them to feel comfortable with me, and so that way they can communicate any issues or problems that they have so that I can feel them at ease when they're at most sick. And they don't know me because I'm not their primary care doctor, so it's nice to make them feel more comfortable if possible. So our team typically consists of care managers, social workers, pharmacists, nursing, and we all work as a team. A typical day would be I'd go up and we'd round, and I'd round along with the nurse. We'd communicate what happened overnight, if anything was needed. And then we'd also communicate to the social workers and the care managers to make sure that we're all on the same page for discharge planning, to make sure that you had everything that you needed for when that time does come. Our team is very large. It's very important that we have very close and tight communication for all, so that way we're all on the same page. We even like to communicate with your primary care doctor, so that way when you do leave, a lot of times I'm asked, will my doctor know what happened? And absolutely they will. Not only do we communicate verbally, but we also send over the discharge summary and full details of what happened. One of our key roles as a hospitalist is discharge planning. We like to start talking about discharge planning early on, so that way you're comfortable going home or going to rehab if needed. If not, we can also ask Catholic Home Services to come to your home and help you with medications or physical therapy. We want to make sure that you feel safe. Our hospice group is actually here. We're here 24/7. We work around the clock, and we're here 365 days of the year. By us being here 24/7, you'll be comfortable, and you'll see a familiar face every morning, and you'll be comfortable with me and your family, hopefully, and you'll know that you and your family are in good hands. As a hospitalist, I'll be your advocate, and I'm gonna do everything I can do to make sure that you're happy in a stressful situation and that you're comfortable. Even the smallest things. Sometimes a lot of people would complain that the coffee's cold, and I would just go ahead and call downstairs and try to get you a hot cup of coffee. I take great pride in working for St. Catherine of Siena Medical Center because I actually live in the community, and I've been here for over 6 years, so I'm actually treating the people in my community that I see in my supermarket and my library. So I take great pride in that. Not only is St. Catherine of Siena Medical Center here for you, but I'm here for you, including all of my colleagues and the entire team.
That looks like an amazing day. How many patients do you see on average, or is every day just simply so different?
Yeah, so on average, it's about 16 to 18 patients a day, yeah. So it can get a little hectic. I mean, other days are less busier. They've done studies about this actually, and they found the sweet spot about 15 to 16 patients a day, and anything above that actually affects the length of stay in the hospital and may affect patient experience as well. So
Wha-
we kind of keep it at that sweet spot.
Yeah, why is that if you see more than that, it affects their length of stay and that sort of thing?
Because you're not going to be as efficient.
Right.
I mean, if you're seeing more patients, you're not going to be as efficient, and you're not going to be able to get people out on time. And as far as if you have more patients on your hands, you're not going to be able to spend as much time with the patient. Therefore, the patient experience scores may actually plummet down a little bit.
Sure. Now, I know hospitalists have been around for probably about 20 years or so, but I haven't really heard that much about them until now. It seems like it's a really kind of booming space in the medical care business.
Absolutely. I mean, the word hospitalist was coined in 1996 by a physician in University of California. Before that, I mean, they existed, but they didn't really have a name. Some of them called them inpatient specialists. But the reason why this doctor wanted to formulate the hospitalist and also formulate a society behind it called the Society of Hospital Medicine, because they felt there was a need to have skilled practitioner in acute care medicine. Like I was saying before, I mean, these patients are really complex. They're loaded with medical problems, a lot of medications on board, and so they need the expertise of a skilled clinician who's an expert in acute care medicine.
Do they always come in through the emergency room?
Usually, sometimes they can come through the cath lab. Let's say somebody is coming in for an elective procedure, and the result of the elective procedure is not very good, or the cath result is abnormal. Then we would admit through the cath lab or ambulatory surgical unit. So most of them are through the ED, though.
We talked a little bit before about the kind of training, and you talked about your own specialties. Do you see more doctors electing to do this? And if so, what do you think it is that interests them so much? I mean, why do you like doing it?
Well, I'll give you my own experience. So when I started my internship and residency, I didn't know what a hospice was. I mean, just like, some people don't know what they are. But I worked alongside with them during my residency, and I saw the difference between a hospitalist physician and a general practitioner. And what I loved the fact that they spent a lot of time with the patient, getting a very detailed history from the patient. Also, talking to the case manager and social workers as far as discharge planning, a safe discharge plan for the patient. And sometimes they touched on sensitive topics, for example, like end-of-life issues. So it's just that the concept of working in a tight-knit team environment, that's what attracted me to hospital medicine a lot, as opposed to the general practitioner who, came in, saw the patient, and kind of left to go back to their office-based practice. There was a big difference, and I fell in love with that, and therefore I became a hospitalist.
I've got to believe you just mentioned the word team, but that's what I'm thinking about is you know exactly where something has to go, like lab work has to do this, and if there's this issue, then I'm going to call this person. I mean, within the realms of the hospital, you know everybody that's in there, which a primary care doctor who may practice in that hospital frequently might not be so acutely aware of where something needs to go.
Yeah, so that goes into the efficiency. So hospitalists are more aware of who to call. Let's say we had to do an MRI or a CAT scan on a patient. I mean, we're going to advocate for that patient. We have the time to do it. We'll call down to a radiology and say, well, we need these tests done. Yes, we are much more aware of the specialist. I mean, some of them, we have their cell phone numbers, and we call them right away for a consult. So as far as efficiency, we get things moving. We get tests done moving very quickly, and we get them discharged rather quickly as well as compared to a general practitioner. Absolutely.
Okay, well, don't go anywhere because we're going to take a quick break. And there's going to be much more of CHS Presents Lifestyles at the Heart of Health right after this. Welcome back, everyone. I'd like to thank our guest for today, Dr. Michael Klott, a hospitalist who has shared with us the responsibilities and advantages of hospital medicine and why he chose this specialty. Now for some final thoughts on how the rise in this profession and how prevalent it's become, not only at CHS, but at hospitals all across the nation. What do you think is one of the best parts that for providing to the patients that you're giving these patients today?
Sure. So, I mean, I think the fact that we're available, so, if a patient is admitted and they clinically deteriorate or they need a higher level of care, for example, they need the intensive care unit, we're right on site. We don't leave the hospital 24/7, so we can attend to that patient right away. The other thing that is sometimes, they may be fine, but they have questions. So we can visit that same patient more than once. It's not just one visit. We could see them 2 or 3 times. I mean, if a patient underwent in a day, yeah, absolutely. So if a patient underwent, a slew of battery of tests and they want to know the results, I mean, they have, they should know the results. So we would go a second time and to notify them what those results are. And also, we're good educators also because, the consultants come in and out and all that, and, they may be talking more about medical lingo and all that. It's the part of the hospital's job is to take all that in and kind of relay it back to the patient in a way they could understand.
So you're an interpreter of sorts.
Yes, I would say so. Communicator and interpreter and a teacher.
And a teacher. That's a big job. So we've got this kind of continuity of care because your shifts are also unusual as compared to other kinds of physicians.
Right, yeah. So the shifts we utilize, mostly it's called a block schedule. So the doctors are on 7 days on and then 7 days off. So basically there's 2 teams, and they're both of them 7 on, 7 off block schedule. And basically what that does is it enhances the continuity of care. Usually the length of stay of a patient is about 3 or 4 days. So we're rest assured that that same physician that's admitting that patient is the same physician that's discharging that particular patient. And that's the best case scenario because you already know the patient. You don't want a lot of handoffs. You don't want to give it to another doctor who doesn't know anything about the patient. The 7-day block actually enhances continuity of care and just better care for the patients.
I bet the primary care doctors, in a certain sense, get this teamwork with you that feel like, well, we're right on top of it too. They're informing us of every step of the way. We don't have to worry about ignoring our patients back in the office. So there must be some relief that this kind of a program can bring to them as well, would you say?
Absolutely. There are a lot of physicians that I would never thought would have handed over their patients to the hospitalists. And, they're the older doctors, with the, other old-fashioned way of coming in, seeing their patients. And they loved the care we provided. I mean, we got good feedback from patients and other physicians, and they've relinquished and gave us their patients to see. So it's an honor. I mean, we're doing a great job. We continue to do a great job, and they like it. Some of them still come to the hospital, though. And what we do is something called treat and release. So we would admit their patients off hours, like in the middle of the night, or during their peak office hours also, and it would release them back to them, and they would see that patient the next morning. So there's a few of those doctors around that does that type of thing.
What happens after the patient is released from the hospital? Where do they do their follow-up work then?
Yeah, so they go back to their primary care physician. So before discharge, number one, we ensure that we route the discharge summary. So the discharge summary is formulated by us, and it's got all sorts of information. It's got lab data, imaging data, and a hospital course, a very detailed hospital course, and all the medications that they're being discharged on. And therefore, that sheet gets routed to their fax machine, so they know. They also get a phone call from us, just to tell them also what happened, and if they have any questions, to reach out to us. If there's any major changes of medication or something needs to be followed up, like somebody's on a blood thinner and they need to get a Coumadin level done in 2 or 3 days, I make sure that I speak to their doctor and make sure that information is relayed to them. Absolutely.
It almost seems like the patient's getting 2 doctors for the price of 1.
That's right, yeah.
Would any of this be possible without modern technology, without cell phones, without the electronic medical records, with all of that?
The EMR is very helpful, I have to say. And a lot of the focus on EMR is because it's got these quality tools built in to help physicians. Now, I'm not saying that the EMR is going to treat the patient, and still it's all based on my own clinical judgment, but it's a tool to help us. Like, for example, if I had ordered a medication that would potentially interact with another medication that the patient is on, it would give me an alert, a high alert, and say, Dr. Klatt, there's a high alert drug interaction. Therefore, it'll cause me to change that medication or not prescribe it. It also detects sepsis. For example, it looks at clinical indicators.
Yeah.
And as you know, sepsis is a killer. There's a high mortality rate in sepsis. So it kind of like it's like a smart EMR. It drags in vital signs, lab data, and it gives you a huge alert on the screen. You see this huge yellow alert and saying, do you want to go down that pathway of sepsis? If I don't feel clinically they have sepsis, I could, ignore that. But if I do feel, it's like, oh, wait a minute, maybe there's something that I missed. Maybe there is something going on. Then I would click that button. It would instantly get me through the sepsis order set, and therefore an order set opens up and it tells me exactly, what to do. Which tells you antibiotics, the fluids. So sepsis is the difficult one because. Initially, it may be very hard to recognize, and I have to say that the first thing in sepsis, the number one step is recognizing the patient has sepsis, and sometimes it could be tricky. So that tool in the EMR is very handy and improves our quality also.
And of course, it also means that you can look at the medical records that come from the primary care physician or the general practitioner too, so that you know what the history might be of this patient who might not otherwise be able to give it to you very cognitively at that time.
Right, yeah, so when they come into the emergency room, it's noisy, patients are anxious, they're uncomfortable, they're not going to give me a very good history. But yeah, you're right. If our EMR is linked, the Epic is linked to their office practice, I could see what tests they've done or when they were last seen. I could see also specialist notes, and I could see test results. So it's very, very handy. EMR is very handy. I can't imagine my life right now without EMR. When I did my residency training at Winthrop, we didn't have an EMR back then. It just didn't exist, or it did exist, but it was in infancy. But having Epic right now, it just makes things a lot easier, a lot smoother, and enhances the quality of care we provide for our patients.
Well, and I'm sure there are plenty of patients out there who would testify to what a great job you've done with them in the hospital.
Thank you.
Thanks so much for being with us today, Dr. Klatt. For more information or to schedule an appointment at one of Catholic Health Services' 6 outstanding hospitals, you can call 1-855-CHS-4500 or visit chsli.org. Thank you so much for joining us today. I'm Jane Hansen, wishing you goodbye and good health.